All right, thanks. And every paramedic that graduates from our paramedic school at the Mayo College of Health Sciences comes out with a degree. So we're on that bandwagon. We've got the special guest today from the Netherlands, and they're going to do a description of the ambulance work in the Netherlands. So Jacob, I can't pronounce his last name. He said I could just call him Jacob.
Why make it difficult if you can do it easy? Let's start with some of the fundamentals. Any ambulance group I've spoken to, there's always somebody who is a collector of ambulance models and who wants to have all the models of all the services. So, for this one person, I've got a Dutch ambulance. It's sold. Sorry. And for the others who were a little bit slow, I've also got a couple of these. And I know there's one that was already lost because he needs to make his collection complete, and he couldn't miss this one, but there's still a lot of it left here. So now it's complete. So having that done, let me first introduce me. My name is, in Dutch, Jaap Hatenboer, or what I said to Gary, Jacob from the Netherlands. As you saw, I brought some bribes with me, and I didn't need them all because I feel a little bit as a party crasher. I was not in the program, so I was a kind of a last-minute addition to the program, and thank you very much for the people from Mayo to leave a spot for me. I'm actually former Air Force. I was an Air Force officer when I came over to the EMS system, and I was kind of a stranger walking in a strange world and trying to understand how this worked. It turned out to be simple and complex at the same time. And that's where you will find it as a thread through my whole presentation, that this is about complexity, but it's also about cutting through complexity. And a part of the complexity is us ourselves because we use words. But just let me begin with the beginning. Probably a lot of you might know the expression, to boldly go where no man has gone before. Yes, I'm the age of the very first Star Trek series with James T. Kirk going on his 5-year mission. Well, for us, it's a more than 5-year mission. Ours started in 2008, visiting Kaiser Permanente in Boulder, Colorado, because we saw our environment changing. And we made a very conscious decision that we needed to be more aware of what's happening around us. So I've been on this 8-year mission with my colleagues, one of my colleagues here with me, to find out what's happening in the world and to cut through the complexity, because there is an incredibly large amount of noise. All these signals, and you try to get through the essential points in what's happening, what is changing. And for us, it was a very interesting journey. It's an ongoing journey, which meant I've been at Nova Scotia. I've visited the New Island Health Centre on Briar Island, or Digby, been at Parsborough Collaborative Emergency Centre, been at Colorado, Christchurch, New Zealand, Canterbury region, very interesting. And last October I was at the Hyderabad Operations Centre of the GVK Emory Ambulance Service, which is, as far as I know, the biggest in the world, running an ambulance service with around 11,000 ambulances. At a price level at approximately 1/100th of that of ours. So there's hardly any money in the system, but still it's very, very effective. And it tells you a little bit about the story I want to tell you, and it goes like, where do we start the story? Does this story actually start at the EMS system? Or shouldn't we start somewhere else? Shouldn't we start at the community? So that's one of the things. What I always also want to say is that I'm very much convinced that if you've seen one EMS system, you've only seen one EMS system. So we know that after we've made this visit, after we've heard all these stories, it will take us a lot of time to really connect what you've been telling to us with our own system. And it turns out that takes by far the biggest amount of energy. Just translating what we're hearing here and then connecting it to what's happening in our system. So we've making one mind map after another, trying to connect and to understand what's the value of all these stories and what's the value of what's happening. And for us, it's day number 3. We started with the Ambulance Leadership Forum. And those who have missed it, you've really missed something, because there were some presentations who were, well, like we felt like exactly drilling down to what's the crucial problem. And we think a lot of the crucial complexity is about how we handle change. And that changing is a very difficult thing for systems. So the problem with being a party crasher is that my slide deck is much too long. There are a lot of videos in it. It means you won't see everything, but I've already given Gary the whole package with the hyperlinks. So I'll suppose he'll put it on the website, and then you can just follow all the videos, which are just illustrations of the story. So it still all goes back to cutting through complexity. And now I'll need to, is it this one or is it the, sorry. I'll point it there, yeah. This is the title, You've Just Been Ubered. I've just put it down because it tells a little bit about what's happening and what our response on it is. We found out that there was a video on YouTube from December 2015 by, I think, somebody called Kimmel about the ambulance and about showing how that might revolutionarily change ambulance services. And of course, the video is in the slide deck, but it's ridiculous. But it's technology, and it's technology that's coming towards us, and it's part of the signals you get, and part of the signals you want to understand, like what is really happening here, and does this really change some of the aspects of our system? Are we in a change process? Yes, we might be. What I wanted to show you first is a little bit about the Dutch ambulance service. It's an animation, it's on the next slide, and it's quite complicated. And that's why I said cutting through complexity, because there's something strange about the numbers. You'll see some numbers, like we've got A1 and A2, and in England you've got the red 1 and the red 2 calls. And, sorry, one back. That's where the video is. Just wait a moment before you start it. This looks like I'm in control, but actually, if you really want to know who's in control, she is. This is just your toy controller. The numbers, they don't fit. It's, we are in the Dutch ambulance service at approximately 1/3 of the workload of an English ambulance service. Our EMS, our A&E departments are approximately at 1/3 of the workload of UK A&E departments. Our general practitioners last year did something like 5 million patient contacts in their emergency assignment, in their emergency system. We are being defended by our GPs. And our GPs take off so much of our workload. And I think that are the kind of things that are lost when you use the same words. An ambulance with us is very compatible, very comparable to the ambulance you use. And that we call it a nurse and you call it an advanced care paramedic doesn't make that amount of difference. But it seems like if you drill down to the numbers, you're looking at a different system. Or you're looking at a system that's differently used. So if you would please start it now. And it's in English. There's an incredibly big sound system over there, and it's not making a lot of noise. This was actually the only thing we didn't test this morning. Last technical solution is put a mic at the laptop. And I think time-wise I could better tell you a little bit about it while you're looking at it. 17 million people, as you saw.
Are received. Ambulance request calls are also received from GP. Every ambulance on the road is supported by an entire organisation. In the Netherlands, there are 25 independent regional ambulance services. They provide ambulance care within their own area. That always starts in the Ambulance Care Dispatch Centre. This is where the 112 emergency calls are received. Ambulance request calls are also received from GPs, hospitals and care homes. The dispatch centre operators have a nursing background. They can assess the situation quickly. They decide whether an ambulance is sent and with what priority. 112 callers are sometimes referred to a GP or out-of-hours clinic. While the ambulance is on its way, the dispatch centre operator gives advice and the first vital care instructions to the 112 caller. The operator also passes on all information about the patient to the ambulance while it's on its way. In the Netherlands, approximately 750 ambulances are stationed at more than 230 ambulance posts. The Ambulance Care Dispatch Centre operator always monitors which ambulances are being used and which are free. On average, 1.2 million ambulance trips are made each year, and this number is likely to increase. 3/4 of those trips are urgent. In a life-threatening situation, the ambulance with flashing lights and siren reaches the patient within 15 minutes. We call this an A1 trip. If there is no immediate threat to life, but a serious health risk exists, this is called an A2 trip. In that case, the ambulance travels without flashing lights and siren and reaches the patient within 30 minutes. Ambulance trips that can be planned in advance are called B trips. For instance, if a patient has a hospital appointment and may require complicated care during the journey, the mobile intensive care unit is also part of the scheduled ambulance care service. If no complicated care is required during the journey, the care ambulance is often dispatched. The important consideration in this case is patient comfort, which is provided by the care ambulance assistance. On occasions, the dispatch centre deploys a rapid responder. That is an ambulance nurse who travels alone in a small ambulance, on a motorbike or a bicycle. Some regions also have an ambulance boat or snow scooter. The ambulance has advanced equipment. The ambulance nurse has been trained to provide high-quality care at any location. The ambulance driver offers medical assistance and ensures the safe transport of the patient. They work as a close team and always according to national guidelines and protocols. If necessary, the patient is transported, following consultation, to a specialised hospital that may be further away. When the patient is transferred, all required information is exchanged. This exchange is increasingly being handled digitally, directly from within the ambulance. 1 in 5 patients do not require hospital treatment once care has been provided. They are often advised to visit their GP. The annual macro budget for ambulance care is approximately €525 million. The ambulance care service employs more than 5,600 professionals. You can always count on them, 24 hours a day, throughout the year. The ambulance staff cooperate with GPs, hospitals, care homes, mental health care services, domestic care services and midwives, and of course, colleagues from the police and fire service. The ambulance care staff are always ready, waiting and professional. Ambulance care. We provide it together.
It sounds a lot like the same in other countries, only the words are a little bit different, and we've got the nurses and, well. But it's a very old video already. And it's not only the staff uniforms which will change, but also how we look at the system. And what I said, if you drill down the numbers, you'll find that the numbers in the systems are different, and they might be, the differences might be so big that you might even think they are actually different systems. That's one thing. But the other thing is also that these acute care systems are changing, and they're changing rapidly. And that's the thing I would like to pick up and look a little bit at what is changing at the moment. And I would just pick up one pathway, just one. That's the out-of-hospital care, the out-of-hospital cardiac arrest pathway, which is changing very rapidly in the Netherlands. And I'll just go by, I'll just pick up the different aspects, because we kind of had the view that we could do this as professionals, and it turns out that we take a backseat in this whole process. And I'll show you how this works in the Netherlands. I'll have to learn this. First, there's a lot of English documentation available. It's already on the memory stick. Gary got it, and our Dutch ambulance organization has it on its website. So, and we do lots of reports, and we've learned to do our reports in English, because otherwise we would just get stuck in our own little 17 million language area. This is, of course, the out-of-hospital cardiac arrest chain of survival. Starts with recognition and ends with the advanced life support and post-arrest care. I often use this one. This one is from Scotland. This one gives a little bit more of an explanation who is doing what at which moment. So it's a more detailed one. And this is how we normally show it. And this is where the lying begins. Let's say where the alternative facts begin. Yes, and we want to be second if you've seen the video. What does this show? It shows somebody who might have had a cardiac arrest. Actually, it's one of our communication guys who didn't have a cardiac arrest, but that's how you make those pictures. Of course, it was immediately noticed. So it was a witnessed out-of-hospital cardiac arrest. There was immediately somebody who started CPR, and you see somebody running towards the incident with an AED. And then in the background, you see the ambulance. And of course, this isn't how it really happened. And this is what I said, it's way cooler than the reality. Because reality is harsh. And the way we look at reality is that we are not anymore in the center. There's something we, kind of borrowed from New Zealand, and they borrowed it from London. So this originates from a project in London. We put the community in the middle. We said this is about the community. So if something which has a time element happens, then your community will be close by. They're the only people who will be physically really close. And then there is, of course, a whole healthcare system, but it's always at a distance. There's always time necessary to get them on location. So we use this to understand that this is actually about where does it happen and what is the environment in which it has happened. What's the community? How does it look like? This is a video I won't show, but we have a kind of warped feeling about time. This is a timer that just times down 2 minutes. And those 2 minutes are necessary for us. That's the lowest estimate. That's what the time we need to decide in the control center what kind of call it is, what kind of location it is, and then to give the incident through to the team, and then the team needs to become mobile. So this is just call taking and mobilization. You haven't traveled a meter yet. You haven't gone any closer to the incident, but you've lost already 2 minutes. So last time I gave this presentation to a whole group of medical students, and I asked them to keep their breath for 2 minutes. And I said, this is approximately what happens to somebody. And normally for us it would take, around 10 minutes to reach the incident. What would this mean, 10 minutes? Well, that's simple. People would die. Survival rate after 10 minutes is practically zero. It's whatever research you grab from the big stack of research on this subject. But if you do nothing, 10 minutes and there's no chance of survival. And all the lines on the graph on the right side, they all go down very quickly. So chances the chance to survive this cardiac arrest or to come out with a good outcome becomes, it decreases enormously every minute, every second. And what you need is very fast CPR, then very fast defibrillation if necessary, and then the whole professional acute care system that kicks in. We found out that it's impossible for us to reach those first minutes. And that means that we have a problem with this whole chain of survival. We are just somewhere at the end of the chain of survival. We're not in the beginning of the chain of survival. Actually, we're not much helping in survival. And that's not a very nice conclusion. So what is our friend? Well, this is one of our friends. One of our friends is, that's the 4th Industrial Revolution. And it's now, it's now like characterized as the fourth industrial revolution, but it tells you something about what's happening in technology. And I'll just skip through this very quickly. But in 1983, somebody was very proud if he could get this phone, which had actually full 30 phone numbers to store, and it cost only $4,000. And there are some movies where you can still see somebody at leaving a prison getting this phone returned when he leaves prison and starts doing all kinds of mischief again. This is where it started. 2007, 2008, technology got in a whole different pace. And of course, we all know these kind of things. And there's one video I'd like to show you. We always tell that technology is difficult and that's difficult in our organizations to change because people have difficulty to change. I don't agree with that, and we'll show in this video, because this is a video that starts in 1999. That's not so long ago. That's well, just count back to your own age at that moment, and people were interviewed about their acceptance of mobile phones.
Heeft u een mobiele telefoon?
Nee hoor, heb ik niet.
Waarom heeft u er geen?
Nou, ik zie er nog niet van in.
Dan ben je aan het fietsen en dan word je gebeld.
Ik heb gewoon een telefoon, waarvoor moet ik een mobiel hebben?
Dat is handig. Maar als ik ergens strand, dan is er ook altijd ergens wel een telefooncel of een boerderij met een boer met een telefoon.
We hebben het jaren zo gedaan en ik vind het wel goed zo.
Als mensen mij bereiken willen, dan kunnen ze dat met een brief doen. En is het dringend, dan ben ik telefonisch thuis te bereiken.
Heb jij wel eens gehoord van een drone?
Drone?
Een drone.
Nee.
Wel van een drone? Stel dat u een drone heeft, waarvoor zou u dat gebruiken?
Aan de buren te bieden hier.
Naar de Albert Heijn.
Ja.
Ja, dat moet ik nog maar eens even zien.
Als een vliegtuig zomaar binnenkomt en dan vraagt aan een hoe noem je dat? Cashier? Mag ik een flesje water? Dat gaat toch niet?
Kunt u zich voorstellen dat u zo'n 3D-printer gaat aanschaffen?
Waarom ik geen één heb?
Ja.
Omdat het niet betaalbaar is voor mij.
Ja, nou ja, nog eens, wat moet je ermee? Heeft u wel eens gehoord van de Google Car?
Google Car? Nee.
Een Google Car, dit is niet je eigen auto.
Ja, het is wel een beetje jammer. Ik vind het wel leuk om een eigen auto te hebben.
Dan hoeven we geen rijbewijs als we 18 zijn.
Ja. U bent taxichauffeur. Maar dan bent u op een gegeven moment natuurlijk overbodig, of ziet u dat niet zo?
Nou ja, misschien wel.
Heeft u wel eens gehoord van de Google Glass?
Ja. Ik stel me nou voor dus dat bij u zit. U heeft fantastische ogen als ik naar u kijk, ja? Godverdamme, hebben ze nou dat dingetje daar voor de ogen zitten?
Ja, dan zit iedereen thuis met zijn Google Glass of in zijn Google Car en zijn drone haalt boodschappen. En als er iets stuk gaat, dan print je het uit. Je hoeft helemaal niet meer met mensen om te gaan. Heerlijk.
Person as an individual have no problem in adapting to new technology if we want it. And I think that's something we need to realize, that if people want something, if they want their driver license when they are 18, they can actually not wait to get their hands on these new possibilities. Like you heard the girl say, hey, I don't need a driver's license to get mobile. That's a little bit worrying if you're parents of like girls in that age group. They perceive it as mobility, and mobility is, freedom. And they like that freedom. So we kind of adapt very easily to new technology, and Google Glass, that's also over. We're now into Microsoft HoloLens. So it seems that we have no problem with adapting to technology, and technology can help us. What we now see is that we used to see one computer for a lot of persons. Now we have multiple computers around us. In my bag, I already got an iPhone and an iPad, and there is a multitude of computers here in this room. That means that we also see new forms of computers. We see these kind of wearables. And that's when it becomes interesting, because those wearables mean that you got computers and you've got connectability. And for the automotive industry, that means that there is a process now called eCall, in Japan it's called decall, which means when a car had an accident, listen to this, when the car had an accident, then the car will call the operation center, the communication center, and will give the details to the communication center and say, yeah, I had 2 passengers, both airbags went off, and I'm here. Please do something. And of course, our cardiologist said, I've got a lot of high-risk patients. I'm now implanting IEDs. They are high-risk components with lots of risks for the patient. Couldn't I put a system like this on our high-risk patients and know more about what's happening to them and get this whole acute care system working without any interference from technology sitting there as a problem in time, as something which needs to be activated. It will activate automatically. And then you're back, and then you see, hey, recognition and activation of the emergency response system can be improved a lot by technology, well-used technology, and people have no problem in accepting it. So they've got number one. There was a number two, I'll just return, immediate high-quality CPR. And that's where our system becomes very strange for you. For every one paramedic, I've got 100 volunteers. Please remember that number. We've got a Heartbeat Now Foundation, and we've got another that's Heart Safe Living. They're now being integrated. We've got well over 100,000 CPR volunteers, which means that there is hardly any cardiac arrest where we arrive where CPR hasn't been started already, which is incredibly important for the patient, but also for the value of the community, because it's actually your neighbor saving your life. Not some professional from far away. They're very happy that the professionals arrive, but it starts with your neighbor. So when we arrive, we see the front door is open and the bikes are already there in the garden. And we know, okay, the volunteers have arrived. We also register the AEDs in the same system, and the AEDs are a different problem because we need to register them very well. And we got a system where we send part of the volunteers directly to the victim, and the other part of the volunteer group is sent first to the AED to pick it up and to get the AED to the location. We found out that the second part, the AED part, is now the more difficult part. And that's where technology can help us. Again, return to the fourth industrial revolution. This is John Kimmel with his Jubilance sketch. I'll skip it because of time, and I need to be within my time, scheduled time. We might use Uber in high metropolitan areas to bring the AED. In New York, they're now getting a 2.2 minute response time. So why don't put the AED on the Uber car and let them bring the AED? But it doesn't solve our problem in rural areas. But there we've got another solution. We already had a student studying on doing a thesis on drones for good and building an automatic drone AED. That might be something for the rural areas. It's a very big step, still technologically, regulation, safety, but it is a way to approach the problem of getting valuable, expensive equipment to a location in a rural area quickly. And I know, of course, that Zipline is already doing something like this in Rwanda. So we're making steps, but it's also a regulation thing. And there is a video about it, and you can look at it if you want to. So if we then return to our chain of life, we see that technology is actually helping us to get the best result out of a community, helped by technology, helped by professional paramedics. And that's the model we see. So we see community and paramedics standing a little bit further apart from each other. The community, that's where you're looking at. You look at technology helping you, and you look at the paramedics supporting the whole system, the paramedic system, as a paramedic supporting the community. And we do these kind of actions, getting as many people as possible, which gives all kinds of troubles. Just one anecdote. We only want registered volunteers. We only want registered AEDs. So all the medical students are being trained in CPR. That's part of their training. And they don't get an accredited degree. They just see it as part of their training, so they do it, they tick the box, and then they are not allowed to enter our system, which is mind-boggling how our system is sometimes so disconnected. What it means for us is that it's all about teams, and that the team actually starts with a community wanting to do more. So we're now experimenting with menu cards, where we can actually start a discussion with the community and say, okay, there are lots of possibilities, how you can work with the fire service, with the police, with the ambulance. It's up to you what you want. if you have a very elderly population, you want to keep them in your community, you want to give the possibility to even die within your community, you need to build something within those communities. If it's more about a young community, lots of students, very young, very active, you build something else. If it's about the fire service being too far away, you build more about fire. So you're starting to have this discussion with a community. And that's something which is brand new for us. We found out that there's a lot of people who want to engage with us. We had never expected that we would be over 100,000 volunteers. And now we're seeing that we need to be activating, helping, assisting, supporting the community, and put the community needs in front of the whole, starting the whole story. For us, that means also a discussion with our own people. So we've stopped writing reports. We switched over to visualizing, and we stole this from the St. John Ambulance Service in New Zealand. And actually, the organization that made the big picture posters for New Zealand has also done ours. So we have switched over to big pictures as a starting point for our conversation with all the other people, all the other stakeholders, and of course with the community. And we've also made animations in German, French, Dutch, but also in English. And that's something I would like to offer to Gary. There is the video, the animation is on it. It's a 10-minute animation, but it's not within my time, my allotted time. So maybe he would allow me to show it during the break. So I'll keep it here. It's now a widescreen, and it doesn't need to be started. That was my presentation. What I just going back full circle. Cutting through complexity, I think, is very important. So just what is really happening and what can we really do and what's valuable. And it's a whole system thing we are doing. And the out-of-hospital cardiac arrest pathway was just choosing one pathway out of a lot of things that are happening at the same time.